Good morning.
Yeah, Dr. Misiani here, Director. Probably let's wait another 3 minutes and then you can start.
Okay, thank you. I think we're 38 in the house already, or in this meeting.
Yes.
Okay.
Good morning. As we wait for our colleagues, let's continue confirming our attendance in the chat box, please. Hello, everyone. My name is Michael. As we wait for our other colleagues, let me just make an announcement on some of the things that we'll be observing as we proceed. One, please let us ensure that our video are off due to the internet connectivity. Secondly, as we proceed, if we have any comments, any question, please let us drop it on the chat box as well. Thank you so much.
Dr. Misiani, should we proceed?
Let's proceed, please.
Okay. Thank you, Dr. Misiani and your team for giving us this opportunity to share the findings of data we collected in November, December. That's PMA, Performance Monitoring for Action, round 1. Traditionally, we start the meeting with a word of prayer. Could somebody volunteer to pray for us?
I'm going to request Amelda, kindly pray for us.
Okay, thank you. Good morning.
Morning.
Okay, wish to pray. Father, in the name of Jesus Christ, I want to thank you, Lord, for this meeting, oh Father. And I pray that as we start, Lord, may you start with you. Guide us through the meeting as we finish. In Jesus' name I pray.
Amen.
Thank you. For purposes of this meeting, just to let members present know, the meeting is being recorded. And I hope there's nobody with an objection to the meeting being recorded. But just in case you have an objection, please let us know and would then be able to discuss with you regarding the recording of the meeting. So at this moment, I would like to add this meeting to Mary and Amelda to take us through to the next points.
Thank you, Prof. My name is Mary Fiongo. I'm working for International Center for Reproductive Health Kenya under the PMA project. So we will be going through the introductions and we will also do the meeting objectives. And because of time, I will ask Amelda to take us through who we have in the meeting, and then we can go through the meeting objectives. Amelda, welcome.
Mine is just to welcome all the members in this meeting. And I want to welcome our CHMT members, recognizing the presence of our director, Dr. Ayub Misiani. You are welcome. Then the sub-county MOHs I've seen, most of them have logged in, and I'm happy. I want to thank you for that. Even a number of facility in charges have also logged in. The sub-county RHCs, I've also seen them. You are also welcome for the meeting. And I think we will introduce at the chat box because we are so many, I cannot name every one of you. We can introduce ourselves at the chat box, but I just want to recognize your presence and say thank you for coming, for turning up for this meeting. Thank you very much. And also to recognize, I've not seen our partner, Afialisi. Okay, they've told me that they will join us in a few minutes. And I think to you, Mary Thiongo, we continue with the meeting as our partners will be able to check in.
Thank you so much. So I want to take this opportunity also to thank all of you because of finding time to be part of this meeting. I think today's meeting is...
Sorry, Mary.
Yes?
I've seen Jacinta Ankote, one of the CHMT members, And I've also seen Maxwell Muganda, our partner from Afialisi. Feel welcome, thank you. I have seen Mr. Mulianga, thank you very much, welcome. Thank you.
Thank you, Amelda. So as I was saying, this is a very important meeting to all of us. I know the county and the partners has been putting a lot of efforts to improve the health indicators of our family planning through the interventions. And so we will be having chances to look at all what is going on, and data will be informing us how the indicators are performing currently. So Kakamega County is a very important county when it comes to family planning work. And we all know that we had the Rwandan Summit, FP 2020, where governments were committing to contribute to improving the family planning indicators, including access to information to women and girls. And we know that His Excellency was the Minister for Planning then. And so his signature was very important to put Kenya to be part of that commitment. And PMA came to respond to make sure that the countries are able to track the indicators and they are able to be informed on what is happening over time. So for the first session this morning, we will have the opening remarks from Japaigo, and the meeting is going to be officiated by Dr. Misiani, who is the County Health Director. And thereafter, he is going to invite Professor Gishangi, who is going to be taking us through the key findings. And we will also have a session to discuss the key findings. And the day is going to be long. After that, we will break for lunch and we will come back for the afternoon session. And the afternoon session is going to help us to further interrogate this data. And we will be able to identify our achievements and our gaps. And we will be able to plan accordingly to see that the data can be able to help us to strategically plan our interventions, and also it can help us in identifying areas that we can work around when we are doing the policy implementation. So the afternoon session will be led by Sam. Thank you, Sam. And Sam, I know he's not a visitor in Kakamega County. He's doing a lot of work in Kakamega County. And so he will be helping us to interrogate the data in the afternoon hours. So without taking much time, I want to give the meeting back to Amelda, who will invite the first person who is doing the opening remarks from Japaigo.
Okay, thank you, Mary. Before I welcome the owner or the officer to officiate the meeting, I want to recognize the presence of the Director of Education, Mr. Ogon. Welcome so much in our meeting. I want to welcome the Director of Social Services, Grace Basieka. Welcome. Thank you. And then now I want to welcome Dr. Misiani, our Director, to officially open our meeting. Thank you.
Thank you, Mel. I think we have skipped a step. Japaigo was supposed to have...
Oh, okay, sorry. Japaigo. Let me first of all welcome Japaigo first, then Dr. Ayub. Thank you.
Good morning. So Nancy Koske, PMA Program Management Unit, focal point for Kenya. So the Country Director of Health, your team, and partners. Thank you for allowing us to have this meeting this morning to share the findings of the survey conducted last year, your county being one of them, with your permission. Under the PMA umbrella, JAPIGO is happy to be part of this important process in providing program management support. As the findings are disseminated, let's look at what the data is telling us and how are we interpreting the data and using them for decision making. It is our anticipation that with the availability of the data, you will be able to identify the key drivers to respond to emerging issues and improve health indicators. As JAPIGO, we want to appreciate the continued collaboration that we've had with the Kakamega County government through the following projects under JAPIGO: AFP, Advanced Family Planning, USAID Afya Halisi, and also USAID Impact Malaria. With that, I want to wish everyone a fruitful meeting. Thank you so much.
Thank you so much, Mary. We want to welcome our director.
Thank you very much, Imelda, and everybody. Good morning again.
Morning.
Morning.
Dr. Misiani is my name, the Director of Medical Services, Kakamega County. Myself also want to take this opportunity, first of all, to welcome each and every one of us to this meeting. I think we've been planning for a while to have this dissemination. For us to look at our data and really what the data is telling us. Before I proceed, I think it's important I recognize the presence of the other directors, social services, education, recognize the partners in the house, USAID supported, to recognize the PMA team, JPIGO, to recognize the CHMT and the sub-county MOHs together with the facility in charges. Why I'm recognizing everyone is because we all appreciate that for us to succeed matters RH, then we need all stakeholders. And I'm very happy that we are having the directors of social services, education in the house, particularly in this period when now we are all concerned about our children, for one, because of COVID-19. And not just because they're not going to school, but also the other a bit about this pandemic, where now there is a hampered service delivery, so that you're having pregnancies, yes, and also on the other hand, you're having Mwananchi not accessing services. So I think for us, the findings will help us to look at the backdrop that right now we are operating in the sense of what can we do better and how can we even evolve to fit the situation that is unfolding before us. So for me, I think it's going to be a long day for us also. I want to welcome everyone. It's not just a 1 hour session. If you look at the program, you're going to have a morning session and an afternoon session. So I just want to welcome everyone. Feel at, let me say, at home. And it's important that we note the findings, and particularly for the sub-county teams, for us to see where we are at as Kakamega County. With the changing denominators in terms of a population, with the census reports that came out, I think this should inform us now on the next steps and the planning that needs to take place for us to address these issues in Kakamega County. So thank you very much, Professor Gishangi and team. I know we've worked very closely with you, we've worked with you, and I'm seeing today as one of the days that we are going to see the situation as was captured then in December, for us now to plan ahead and look carefully, particularly now that we are discussing about the journey to self-reliance, and we have several transitions for us. For one, we know that 2020 is here. We know that 2022, again, there's going to be another transition. We know that USAID also is transiting most of the projects that we've been having. Previously, the coverage would have been, say, the 12 sub-counties, but you are seeing projects increasingly reducing the support to the key targeted areas. So I think it's important also as a county, as you're having this conversation, we think about sustainability, we think about the journey to self-reliance, we think about resource mobilization, looking at the non-traditional support, because I think we've been looking oftentimes at USAID and the other multi-national partners, but I think a time is coming where now we have to look at the local and the grassroots support from the community-based organizations, from the various community groups that we have to ensure that we take this agenda back to where it's supposed to be, and that is the community. So for me, it's to welcome everybody and to wish that we all participate and that we have a fruitful day. So thank you very much and welcome all.
Thank you, Dr. Misiani, and thank you, the CHM team. Michael Waithaka, I need to share my screen. So members, just give me one moment so I can share my screen. Michael, are you sharing your screen? I can't share my screen. Michael Waithaka.
Someone, Daniel Miano, kindly and share your screen. You are the person who is sharing the screen right now. Miano. Daniel. Share your screen. Prof, you can now share.
Okay, let me try.
I think it's usually 40 to 200,000. Yeah, I think we are also looking at it. We are also most likely going for it. But you guys are, so we'll go for it with other partners.
Maybe I'm not able to see my screen. Medithiongo, is there somebody sharing their screen? Because
No one who is sharing the screen right now.
Your BD unit already has somebody, an organization that they have partnered or they had approached. Yeah, I guess that's because.
Michael Waithaka, okay, now I've got it. Okay. So thank you, Dr. Misiani and the team, and thank you, partners present. I would like to take you through the findings of performance monitoring for action. The data collected November, December 2019. My name is Professor Peter Gichangi. I'm the principal investigator for PMA projects implemented by International Center for Reproductive Health. Just to note that this work is led by Ministry of Health, NCPD, and Kenya National Bureau of Statistics. ICRH is one implementing, and we have all the other partners who support this activity. So in terms of government agencies, I've mentioned the Ministry of Health, both national and county. We have NCPD, KNBS. KNBS role is particularly important because they selected the counties, the enumeration areas. We do have support from other universities, Moi Technical University of Mombasa, where I'm currently, Jaramogi Oginga Odinga University of Science and Technology, and University of Nairobi. We do have technical support unit at the Bill and Melinda Gates Institute for Population, Reproductive Health at the Johns Hopkins University, and we have project management unit, which is in Japaigo, and Nancy is representing that particular unit. And the funding comes from Bill and Melinda Gates Foundation. So we have to appreciate this structure. This is how PMA works. For those of us who have listened to this presentation, my apologies for this repeat, but again, for the new partners present, it is important we go through it. So we have a person we refer to as a resident enumerator. So this is a young lady who resides within the enumeration area, the area where we collect data, or nearby. So this person then is responsible to conduct interviews at service delivery points, private ones, if they are within the EA, as well as the households which have been selected within the EA. So this lady is equipped with a smartphone, and that smartphone has the questionnaire, which ordinarily would have been the paper and pencil questionnaire people are used to. You go and record in a piece of paper. But in this case, we record that information or capture that information in a smartphone. So this person then submits the data collected to a central server where aggregation of the data happens. And then we have the team, the central team, who look at data being submitted on a real-time manner or real-time basis. And that allows us to see the data being submitted is complete, the questionnaires have been submitted accurately, and if there are any issues, then they are immediately identified and discussed with the county supervisor and the resident enumerator. So data cleaning is an ongoing process. And once data has been submitted, final cleaning is done, then you're able to produce reports or fact sheets or interactive dashboard. Indeed, we have several dashboards, and we'll be sharing that as time goes by. And then from that, then we are able to get to the end users. And indeed, as we are sitting in this meeting today, this is now the end users receiving these reports. As the director has mentioned, this has been the planning for a long time. We have a unprecedented situation with COVID-19, which curtailed movement. But again, for every problem, there's a solution. We are now able to disseminate virtually, which has its own benefit. But of course, the warmth of being together is being missed. Now, what is the design? When you look at performance monitoring for action, this is a panel design, as you can see on your screens. And this design is in such a manner that we are able to, with the women we interviewed in November, December 2019, we shall interview those women November, December 2020, and November, December 2021. If you look at that band, it is narrowing as you go to year 3, which is naturally expected, because some people may move out of the enumeration areas. Some people may be out of range in terms of age, more than 49. And you also have individuals who are 14 who may become of age and join the cohort. So this is an open design. Within this open design, we are also able to collect sufficient information for us to do point estimates. And that is a cross-sectional part of it. So we shall have a panel design throughout, but with cross-sectional design each year. So each year we shall be able to produce a point estimates. What we are disseminating now are point estimate from the cross-sectional design for first year, which is in November, December 2019. Now, so that is a household level. At the service delivery point, we have a panel also where service delivery will include private facilities and public facilities. And for this, you notice up to year 3, they are constant. We don't expect any facility to be closed or many new ones to be added. What do we do at the service delivery point? We do an inventory. We do have a check of the questions, which allows us to determine whether products are available, whether there are staff who are trained to provide products. But we also do what we call client exit interview. So these are persons who are exiting a service delivery after receiving services. And we shall do that for both public and private. 6 months, we shall repeat a current exit interview, and then that continues up to year 3, which is 2021. Just to note that the household panel is linked to the SDP panel. So that allows us to see what is happening at the household level and how does that relate to the SDP level. So these are the enumeration areas selected within Kakamega County. We have 6 which are considered urban as defined by Kenya National Bureau of Statistics. And we have 19 which are again defined as rural by KNBS, a total of 25 enumeration areas. This is what is called the S-curve, which is a plot of the point estimate for different counties in Kenya based on 2014 demographic and health survey data. What you notice is that we have areas where use of family planning, modern method of family planning, is as low as 2%, and some areas which is as high as 70+%. You can see Kakamega is in almost to the area of what we would call the plateau between 60 and 69. So it's in the area of 50 to 59. This is important because as your county gets to the level of a certain CPR, then you know the amount of growth which can happen is going to be limited. In fact, most of the time, you'll be sustaining your level of use with very limited growth. And this should not be disappointing because we know that you're not expecting any county to have an MCPR of 100%. If you're having a face-to-face meeting, I would have posed the question, what would happen if everybody was using family planning in Kakamega County? I know we are not together, but that's an important question because if we are at 100%, it means no babies will be born. And what will happen to the population? So those kind of things are important for us to consider as you're looking at our programs. So what were the findings? What we see in this slide is that we have very, very good response at both the household level and for our target population. Our target population is women aged 15 to 49 years. What we see, both rural and urban, we had over 99% response rate. We ended up with 830 households were interviewed. And from 830 households, we had 728 women who are eligible. And we interviewed a total of 723, meaning only 5 women were not interviewed. Again, response rate of over 99%. So we truly appreciate the response for the team from Kakamega. It means that when you have such a good response rate, the data is reflective of the population it was meant to provide indicators about. So what were the age distribution? And again, as per the Kenya population pyramid, we know that we have a lot of children who are below 1 to 5 years. And this is reflective of that particular population pyramid, where 22% of our participants were aged 15 to 19, and as expected, about 9% were 45 to 49 years old. In terms of wealth, we see nearly good distribution, where we see the highest wealth quintile, that means the wealthiest, and this is calculated from several questions, that 32% were found within the urban areas and 68% were found within the rural areas. And we see the same, and we notice that the lowest wealth quintile, most of the people are from the rural areas. Only 3% were found within the urban areas. We need to remember this because we have several slides we'll be looking at wealth quintile and the different indicators. What were the education status of our participants? we see that Kakamega, only about 2.3% of individuals did not have formal education. 49% had primary education, 39% had secondary education. But you also note only 2% have attained university education. And I think this is probably what we need to be able to be moving the needle towards university education. What were the marital status? Again, very reflective of the Kenyan situation. 56% were married, 31% were never married, and the others in between. So let's look at use of family planning and demand indicators. Here we see, we started working in Kakamega in 2016, and we are showing 4 data points from 2016 to 2019. And what you notice is that for all women, which is the red line, is almost constant. 2016, it was 49%. 2019, it was 47%, a slight drop of 2 percentage points. What about married women? We started at 68%. We are now at 62%. Clearly, there is a drop in modern contraceptive use among married women. And we see a fluctuating point estimates for unmarried sexually active, overall with an increase from 45 to 66. Now, if you look at the method they use, they are categorized into 3 categories: 1, traditional method; 2, short-acting method; and 3, wrong-acting methods. Wrong-acting methods give more protection. Short-acting methods have more failure rate. Traditional methods less effective. Now, looking at all women, we see a slight increase in traditional method from 1% to 2%. We see wrong-acting method an increase from 23% to 25%. And we also see a decrease in short-acting method from 26% to 22%. Certainly, as wrong methods are increasing, short-acting methods are decreasing. That is for all women. If you look at married women, we see that the traditional methods have increased from 1.4 to 2.5%. We see that the wrong-acting method, we started at 33%, we are at 34%. At those 2 time points, no much change, but you notice there was a decrease in 2017, an increase in 2018, and now a decrease in 2019. We really need to be watchful of this group. Traditional method, the short-acting method, we have a decrease from 35 to 28%. So there's something which is telling us, and we need as a team to look at it and say, what happened between 2017 and 2019? We are on a good trajectory, but then things have changed. What are the methods people are using in Kakamega? Again, if it was a face-to-face meeting, I would have asked somebody to interpret this slide for us. What you notice is that there are 2 prominent colors. What I would consider red. I am sure I'm color bright, but others may have called it something else, but this big bucket of looking red. And here we see that in 2016, we had 36% of people using injectables. And in 2019, we had 3% using injectables. The second one is blue, or a shade of blue. And we see in 2016, we had 33% using implants. And in 2019, 46%. So clearly, we see an increase in implant use over time. We see a decrease in injectables over time, a much more a decrease. Now, are there differences between married women and unmarried sexually active women? Again, if you see that slide, there are 2 colors which are prominent. What I called red before, this is implants. We have married women, 47% using implants, and unmarried but sexually active women, 43% were using implants. For married women, we see that 36% were using injectables compared to 18% for unmarried sexually active women. But what else do we notice for unmarried sexually active women? They use condoms quite often. 30% reported using male condom as a method of family planning. So you can see clearly there are different method mix depending on whether one is married and whether one is not married, and that should carry through when you're counseling our participants for family planning. And this is to emphasize that we see a significant increase in implant use among married women from 34% in 2016 to about 47% in 2019. Again, if this is becoming popular, we need to be watchful that this method is in stock. Otherwise, then a lot of people may be disappointed. What is satisfying is to note that 100% were cancelled on how long the implant will protect them. And that is important because they will expire at some point. And 95% were told where they could have the implant removed. And I know at the national level, we have a conversation about preparedness for implant removal when this becomes due. As a county, as you're seeing your implant increasing, also we need to prepare ourselves. How do we get these implants removed when they expire? So let's look at methods use and unmet need among all women. And this is showing us, in fact, the other way to look at this slide is looking at total demand. We see 46% in 49% rather in 2016 were using modern method. What we don't see much of a change in terms of unmet need for spacing, as well as met need for remitting. Members, you can still hear me?
Yes, we can hear you.
Yes, we can hear you.
Thank you.
We can hear.
Warning about my internet being unstable, so I just wanted to make sure. So let's look at married women, and we see a similar pattern, 68% coming down to 62%, and we see changes. The size of the bar is actually the total demand, and we see that there are changes over time in terms of total demand. And that is now shown here with this line chart, where we see that total demand for all women has moved from 61% to 58%. So that's a decrease. But what is satisfying is to note that the program has remained responsive in providing modern methods. This is demand satisfied with modern method was 79% in 2016, and is about 81% in 2019. That's again a mark of quality of services, because it means women who want a method of family planning, they are getting a modern method, which is more protective. Married women, we see a very close pattern that total demand has decreased from 82% to about 75%, while demand satisfied has remained about the same, 83 to 81%. So let's look at other important elements, equity, quality, and access to information. And what we see here is, if you look at use of family planning, unmet need, and demand satisfied by wealth status of the participant, what you see for all women, that there are not much of differences between the lowest wealth quintile, which is Q1, and the highest wealth quintile, which is Q5. We are looking at use, 44, 48%, not much of a change. However, at the bottom of that chart, you notice that for the poorest or the least wealthy people, only 76% of their demand was satisfied with modern method, compared to 86% for the persons from the wealthiest quintile. So wealth has something to do with your demand being satisfied. We see the similar pattern for married women, about 77% in the least wealthy people to about 86% for most wealthy people, while the changes in terms of use and unmet need, we don't see much of a change, except the unmet need has reduced from about 12% for the lowest to about 6% for the most wealthy. But you notice quintile 4 unmet need of 13%. So generally we see wealth has an impact for both all women and married women in terms of demand satisfied. You're looking at, does area of residence matter, being in a rural area or urban? And what you see, yes, there's some difference. For rural area, use is 46%, for urban area is 51%. But you see that urban area unmet need is 13% compared to 8% for rural women. The difference is that in terms of rural women, 82% of their demand is satisfied as compared to 78% of those in urban areas. Again, a reversal of what one would have expected, but the differences are very small here. When you look at married women, we see a slight decrease from 63% use for rural to 58% for urban. And again, we see similar pattern that rural women are having their demand satisfied more compared to urban areas. So again, we may have focused all our attention to rural areas. This slide is reminding us to also review and intervene for the areas we would consider to be urban. Does education matter? And we'll see, what we see here is clearly confirmation that education indeed matters in terms of family planning indicators. For those with no education, remember it was about 2.3%, 34% was the use for no education, and 47% for those with primary or higher education. And you see demand satisfied again is lower for those without education than those with education. And the similar pattern is seen for married women. 37% for married women with no education, 63% for married women with education. And we also notice that for both all women and married women, there's a little bit of use of traditional methods compared to those with primary or higher education, being reported at 9% for married women, 7% for women, for all women. Let's look at other elements of quality now. And here we are looking at 4 questions, which are called Method Information Index Plus. I would like us to look at the no part of it. And so the first question, were you told that you could switch to a different method in future? And 25% were told no. Were you told by a provider about methods of EPI other than the method you received? And we see 28% said no. Were you told what to do if you experience side effects or problems? 92% said yes, only 8% no. And when you obtained your method, were you told by a provider about side effects? We see 34% said no. What is important for us to note is that only 49% of our participants received or said yes to all these questions. It means a substantial number of our participants are not receiving information on these important elements, which then define quality of our services. So as CHMT, as partners, we need to be thinking, how do we address this element? What do we need to do? I think from this slide, it's probably some intervention we can do without additional money. It's about counseling. So that is something we need to think about as we are looking at the gaps we are identifying from this data. 52% were told about advantage and disadvantages of a method during the last visit. It may sound very simple, but I think this is a particularly important question. If a woman is challenged by another woman in the village, why are you using a family planning method? And they are not aware about clearly about advantages, disadvantages, then you'd be at pains to explain why. But you also note other elements are done very well. Obtained a method of choice, 92%, 97% were satisfied with the services, and they'll refer somebody to that facility. So clearly, there are areas, again, which is counseling, where we can be able to improve. We note that 88% of our participants had been exposed to at least one source of family planning method. And I was looking at this slide, I wondered whether to call the radio the king or the queen, because we see that the radio is the one reaching most of the participants. 2018, 89%, and 2019, 85%. Television follows closely, with 53% reporting exposure to a television message in 2019, 47% in 2018. We have introduced a new question about social media, and we see nearly a quarter of the participants said they have received a family planning message through social media. So again, this is signaling a revolution in terms of how we can use different channels to reach different audiences, to be able to reach, pass the message on family planning. So let me now focus my attention to myths and misconceptions about family planning. So here we captured several questions, and we have just highlighted two of them. And we captured opinions about myths and misconceptions regarding family planning. And the first part of the question, we wanted to know, if you are in a community, what do you think is the opinion of the community that adolescents who use contraceptives are promiscuous? And we see that the respondents said 58% of the community members may be of that opinion. When we asked it, now you yourself as a participant, what is your opinion about the statement, adolescents who use contraceptives are promiscuous? What do we see? 51% strongly agree. Then we have to ask ourselves, is the program, is that statement correct? No, it's a myth, it's a misconception. And then we asked something about family planning is only for married women. And we have other questions. What is the community opinion? About 39% would say yes, it's only for married women. And when you ask a personal opinion, we see that 40% strongly agree or agree. So this is something, again, we need to think about. How can we turn around this fact? I mean, this message is not a fact. Family planning is not for married women only. Any woman who is sexually active deserves and is eligible to use family planning. Then we have broken that question by age categories, and we notice that 15 to 49 on the question of promiscuity about adolescents, and 46% agree. So this is huge. If you are an adolescent and your colleagues will see you as being promiscuous because you're using family planning methods, then that could be a significant deterrent. 44% of adolescents, 15 to 19 years, are of the opinion that family planning is only for married women. Again, it would be such a deterrent if an adolescent was going to discuss with their contemporaries or their peers that they're using a family planning. And if the opinion is permissive in the community, then you would be at pains because you're not married while using family planning. Now, we have always talked about partner involvement, male partner involvement. And here we highlight the perspective from the women participants in the study. What do we see here? We asked a question, before you started using this method, had you discussed the decision to delay or avoid pregnancy with your partner? What do you see? 72% said yes. But you also have 29% who did not discuss. Does your partner know that you're using this method? 81% said yes, their partners know. But you also have 20% who did not know. Now, we wanted to know who mainly makes the final decision to use a method among current users. And what we see is 60% of the times the man is involved. 49 is a joint decision, and the men, 11% make that decision. Who mainly makes the final decision not to use a method among non-users? And what do you see there? The woman is the person who makes a decision not to use. So clearly, if you have presented with a situation where somebody is not using, you know the person who makes that final decision is the woman. So you can deal with that person at that point. So this previous slide and this slide does indicate to us there is indeed male partner involvement as perspectives from the female participants in this study. Now let's look at a concept of women and girls empowerment. Does it have anything to do with family planning? And here we are looking at existence of choice or being able to negotiate for family planning among women. And what we see here clearly from these two questions, I feel confident of telling my provider what is important when selecting an FP method, and 69% strongly agree. So they can exercise choice. And I can decide to switch from one FP method to another if I want to, and 68% again are saying strongly they agree they can do that. But on the extreme end, we see 10% and 12% of the individuals do not feel they can exercise their choice. And we asked a question, so this is for all women. Is there existence of choice for family planning? You know, the previous slide was, can you exercise choice? Now here we are looking at, does that choice exist? And these series of questions do show us that yes, if I use FP, my body may experience side effects that will disrupt relations with my partner. What do you see there? 20% saying yes, they strongly agree, and 14% agree. So that is 34%. And we go down to the last one. If I use FP, my partner may seek another sexual partner, and we see 15% again strongly agree. So those are extremes. For those individuals, existence of choice does not happen. So we are seeing somewhere between 15 and 34% of the participants expressing inability to, expressing the fact that choice does not exist. We saw in the previous slide about 10% not being able to exercise choice. So then we calculated an index which is called Women and Girls Empowerment Index from about 17 questions. And this is calculated to a score of 1 to 5, 5 being the highest empowerment and 1 being the lowest empowerment. And then we look at the chart there and we see that the lowest empowered women, only that 3% were using a method, family planning, or using modern method of family planning. And that goes to 55% among the highest empowered women. And we looked also at intention to use in future. We see lowest 15%, highest 12%. So clearly, empowerment has something to do with use of family planning, particularly modern method of family planning for this particular population. Just to say that we have seen this across all the counties where we are, and this is a common theme now. It means that if we can do anything to empower women, then we could only look for better times in terms of use of family planning. So let's look at now at adolescent and youth sexual and reproductive indicators. So from the participants, we noticed that 15 to 19-year-olds, 29% reported they had ever had sex. So a third of our participants, 15 to 19, reported they have ever had sex. We wanted to know how willing were they to have the first sex. And what we could see there, 60% were equally willing. Only 39% was a partner more willing than the participant. So who is the partner here? The male partner, because our participants are females. We also wanted to know, this first sexual episode, was pregnancy prevention desired or not? And a way of telling us, did they have that knowledge before? And what we see is 65% desired to prevent the pregnancy. Of the 65, 71% used a method to prevent the pregnancy. So clearly telling us the circumstances around the first sex, the idea of pregnancy prevention was already there. But we also wanted to know what were the motivations of the first sex. And we see these are multiple response, so the total is not up to 100%. What we see here is that 69% of our girls 15 to 19 years were just curious. I don't know as parent what we can do about that. I know there's somebody from education. I don't know what we can do. 25%, I was under the influence of substance. 30%, I was carried away. 17% was forced against my will. 23%, I was doing what was expected of me. Somebody has said the sexual behavior you see among adolescents is one way of is a reflection of our values. And I'm not sure that we have socialized our children to know that having sex 15 to 19 is doing what is expected of them. So this is generating a lot of information we can package, and we can look at it and see, are there things we can do? So we note that 29% were sexually active, meaning 71% had never experienced sex. So what can we do? Is there anything we can do to keep these non-sexually active adolescents? Yes. And we wanted to know, how much do you think you'll be involved in decision to have sex for the first time? Well, we noticed that 51% say they'll be very much involved, 29% not very involved, and 20% they don't want to be involved at all. So clearly there's a proportion we can keep because they're not interested. There's a proportion probably we can do something, not very much, maybe you can bring them to not at all. But it's also a proportion where we have to probably live with the fact that it might happen. But again, this is a debate we can have as CHMT and partners to see how do we deal with this kind of information. Then we looked at young people, 18 to 24, and we wanted to know by the age of 18, which is the age of majority in this country, how many were married? And we see that 11% were married by 18 years, 48% had first sex by 18 years, 12% had used a contraceptive method, 19% had a birth by the time they were 18 years. So clearly, there are things happening to our young adolescent and young people, and there are many things we can be able to help them. Then we looked at, are there differences between urban and rural in terms of reproductive health, basically sexual activity and contraceptive use. And we see here, the age of first sex is not very different, 17.8 years for urban, 17.3 years for rural. At the extreme end, we see that by the time the rural women were having to use contraceptive method, they had 1.6 children on average, while for urban areas, it was 1.4 children on average. Slight difference. And of course, the question of how can you have 1.6 babies or 1.4 babies? This is an average. So there's girls without and there are girls with 1, 2, 3, and depending on, so that you can come to that average. We wanted to know, are the adolescents being left behind? Particularly if you look at the married adolescents. And what you see clearly here, they are significantly being left behind. Any married adolescent, in terms of MCPR, modern method use, it was 9% compared to 49% and 60% for women 24 and 25 plus. Those who are married, we see that 40% were using a method compared to 57% and 63%. So clearly they are being left behind, even those who are married. Sexually active, we see 36% compared to 65 and 69%. So in this slide, in summary, tells us the adolescent girls, all or married or sexually active, are being left behind in terms of access and use of family planning. And where would they want to get the sources of family planning? We see adolescents, the most registered facility in this county is Government Health Center, followed by other outlets and pharmacy. When you look at young women, the Government Health Center is a prominent one, government dispensary, as well as government hospital. So again, this can help us think if you are to target different segments of adolescent and young women, where do we place our products? When I look at teenage pregnancies, marriages, and motherhood, what we notice at the time of the survey, 11% had given birth, 1.1% were pregnant, therefore 12.2% were actually mothers or pregnant at the time of the survey, while 6.4% were married or living with a man as a family. So 12% could be seen as improvement from the national average, but you have to look at the county itself to say progress. So let's look at method used during the last sex among adolescents. We notice that 56% did not use a method. Condoms, male condoms were used 28% of the time. Implants and injectables were being used at that time. So again, fast sex, quite exposed, and this could explain why we are seeing quite a rapid increase in HIV among adolescent and young women. Wanted to know, would people feel ashamed or embarrassed about obtaining methods of family planning from somewhere? And what do we notice here? That if the adolescents were going to the clinic, they will feel embarrassed 49% of the time. If they're going to a pharmacy, they will feel embarrassed 50% of the time when you compare to the others. So clearly, there are many things which are against the adolescent from having access to family planning methods. As you can see, nobody wants to feel embarrassed if they are going to take or to access a product. Now, we looked at what was the willingness to have sex for the last sexual episode among adolescents, 15 to 19. And we see that 48% were willing to have sex, 52% were not willing to have sex. And what were some of the reasons? The people were not interested in having sex at that time. They were pressured by their partner to have sex. They did not give consent and therefore they were forced to have sex. Or they felt at risk of violence if they declined to have sex. Again, it calls for education and many other things we can do to be able to address this kind of situation. So let's now look at service delivery points. What we notice is that 77% of the women reported to have received their method from a public service delivery point. So in Kakamega, 23% of the people would access methods from elsewhere. And which is that elsewhere? It's private facilities, mainly pharmacies and other clinics. So in Kakamega, we had 100 facilities, 86 public and 14 private. And of those, we see that all public facilities were offering methods of family planning compared to 79 private. 50% of the public facilities had a mobile outlet or mobile facilities compared to only 14 for private. And that only 52% of the public facilities were supporting community health workers or community health volunteers, compared to only 2 facilities, which is 14% for private. Clearly, again, community health workers or volunteers is an opportunity to provide services, but that probably with few supporting, then we may need to think as CHMT, what is our strategy? Let's look at the different products. And we start here by looking at intrauterine device. What do we see in terms of stock and stock out levels? Clearly, we see in 2016 there were issues. 76 were in stock, 10% were not in stock for previous 3 months, and 10% were currently out of stock of IUDs. What do we see in 2019? 86% were stocked, 1% were out of stock for previous 3 months, 7% of the facility were currently out of stock, and 6% say they don't offer. If you compare 2019 and 2018, you see significant differences. Clearly, 2018 was the best year for Kakamega in terms of IUD, but something is happening. Implant, let's look at 2016. 14% were out of stock 3 months before, and 7% were currently out of stock. 2019, we see the similar trend. 16% had been stocked out 3 months before, and 5% were currently out of stock. Again, you compare these two time points with 2018, 2017, different stock levels. And remember, we saw that there's a decrease in method mix. We need to revisit that particular slide. What about injectables? There was huge stockouts in 2016. We don't see the same. We see it is 6% in 2019. So injectables, we are improving, but note 16% reported they had been out of stock for 3 months. Condoms, doing well in 2017, 2018, but not very well in 2019 because we have 9% reporting stock out 3 months before the time of the survey. Pills, again, we see evidence of stock out. 2017 was the worst, where we had 32% out of stock at that time point. But here in 2019, we see 11% reported being out of stock for 3 months before, and 5% currently out of stock. In terms of the facilities providing 3 or 5 methods, modern method, we see that all the hospitals have 5 methods. Health centers, only 93% have 5 methods, they have 3 methods. At dispensaries, only 89% have 3 methods. In total, we are about 92% of the facilities having 5 methods. In terms of preparedness, we see that facility preparedness for implants, that 79% were prepared. Why? Because they had a trained provider, they had instruments and supplies needed for implant insertion and removal. We see 79% were also prepared for IUDs. Those are trained staff, they had instruments, they had supplies to be able to insert and remove IUDs. So clearly this preparedness is reasonable. It could be improved because ideally it should be 100% to be able to provide those particular methods. So in terms of key highlights, we see there is a slight decrease in modern contraceptive use since 2016. Related to that, we see there is a slight decrease in demand for family planning, but we also see that implant is becoming the dominant method in Kakamega. We see that among women who are using modern methods, 20% reported that their partners did not know they were using a method, but 80% of course the partners knew. And that women who are empowered, we have seen they are likely to use methods, and that quite a number of adolescents and young people had sex by the time they were 18 years old, about 48%, and many had used, only 12% had used a family planning method. Stockout still remains an issue to be addressed. It is improving, but there's still work to be done regarding stockouts, which could also explain part of the reasons why we are seeing a decrease in use of different methods of family planning. So here we need to look at how can we continue to monitor demand and be responsive as projects, as programs. We also need to look at adolescents and a young person's health, and see the implementation of documents pertaining to adolescent and young people. How are we doing with those implementation? We also need to look at how do we work on myths and misconceptions about family planning, and how do we then address the challenge of stockouts. So programs need to really look at low-hanging fruits, and I would consider here counseling, which you have seen several method plus index, individuals who are told about advantages and disadvantages of family planning. We need to look at issues of access, equity, and quality of services. We have seen there are issues there. We need to issues of how do we ensure commodities are in places where they're required and that facilities are able to provide. And how do we look at generally speaking, education of adolescents or information to adolescents to ensure that whatever sexual and reproductive health decisions they make, they do have sufficient information and they're able then to act accordingly. Finally, is to really thank all the collaborators, all the logos you can see here. Different teams have different contribution, like we have seen John Hopkins, the Technical Support Unit. We have seen JPIGO, Program Management Unit. We have seen Minister of Health, which leads a project advisory or technical advisory group for the project and gives direction, Kenya National Bureau of Statistics, selection, and ensuring that whatever we do, for example, there's an element called weighting of the data. They have to really confirm that the data has been weighted accordingly so that it can be reflective of the country findings. NCPD, Population Matters, ICRH for being the lead in terms of implementation, and the universities I mentioned, Nairobi, Jaramogi, Technical, and Moi, for the intellectual input they give us to be able to run this project efficiently and effectively. And finally, is it to thank this team of young ladies, and of course we have a couple of men, supervisors, who, were not for their efforts, selfless efforts, and the things they do, will not be able to share this kind of information. Again, we have had very good, consistent data because of what they do themselves, and this is particularly appreciated by me as a PI, by the team, by ICRH, and by partners we share this information to. So again, here to congratulate and acknowledge the contribution of our resident enumerators. They are actually the pillar of this program. And finally, to thank Mary Thiongo for our leadership of the technical team and the ICRH team for their good work, and JPIGO through Nancy for the support in terms of project management unit. And again to you, Dr. Misiani, and your team for allowing us to do this work and being supported throughout as we correct data. And particularly, I would like to single out our colleagues, Sam Murienka from AFP, for again being part of this journey as where we overlap and where we look at things together. So thank you very much and have a good day. Now be ready for questions. Thank you. Back to you, Dr. Misiani.
Thank you very much, Prof, for that elaborate presentation. Thank you very much for that elaborate presentation. I want at this juncture to welcome, I know we were to have in the program a discussion on the findings and policy implications. I wanted first of all to open the discussion to the members. It's a very long and detailed presentation, very many things that you can react to, but probably just a few questions first for us as we try to digest all that. So for me, I would invite from the participants if we have any questions, concerns raised.
I've seen some questions on the chat box.
Yes.
I've seen a question from Dr. Nasimiu saying about consistent use of condom.
Mhm.
Maybe if Dr. Nasimiu is present, can be able to air out the question.
Thank you, Melda. I think my question is, and I've posted in 2 questions.
Yes.
My first question is about whether this can be drilled down to sub-counties, because I'm interested to get the picture of my sub-county. Then the second question is on the use of condoms, about, you know, I think condoms, it's more important to know about consistent use of the same and whether they have any information about that. Then lastly, my third question is, I'm looking at this as a, you know, kind of TD, a follow-up in 2020. In terms of interventions, you know, does this have an intervention arm to it so that we have a reasonable expectation of change of indicators over time? What are some of our interventions that we are looking at to kind of inform this indicator change over a period of time?
Thank you, Dr. Nasimiu. I think also the questions that we are asking, really, we are asking ourselves. We are not asking the team that has given us these findings. I think the findings are from our own population. So it's important as we ask, let us appreciate that we are asking ourselves first, and then also PMA and the other partners can add into the conversation.
True.
Any other question? I'm seeing Esther Mboya, true reflection from the ground. My big concern is what we are doing on continued stockouts, especially on the preferred methods, implants. Mboya, you're around?
I'm around, Daktari.
Yes, can we just ask the question again?
I have a concern that from the presentation, if I got it well, then it's like stock out of preferred method as it featured in the presentation is still on. And I remember sharing this with Division of Family Reproductive Health, that I'm not speaking for the county, but I'm speaking for Lurambi. We have had continuous stockouts of implants, and it's going to hit us even more in this year. So what is it that we can put in place now that we have already identified our gap? Now, how can the partners step into bail us out of that?
Okay. The question is noted.
I have a question, Dr. Misiani.
Yes, that is Maxwell.
This is Maxwell from Afya Halisi. And first of all is to thank Prof for this actually excellent and wonderful presentation. And therefore, as implementing partners, then we're able to tease out some of, things that really we need to focus on. So my first question was whether they computed any information on method discontinuation, focusing into the leaking bucket phenomenon, where you put women on family planning and you have some that are exiting. So if you have any data or any information that you collected on method discontinuation, it will actually help us to understand. Secondly, is just to echo on the issue of contraceptive counseling, where the method information index was only 49%. The question that I would want to ask around that is about whether you narrowed down on women who presented with side effects, and whether the kind of counseling that they received once they presented with the side effects. Lastly, maybe it's just something to note. If you look at contraceptive uptake amongst married women, which is primarily driven by condoms, and this one actually goes to what Dr. Nasmi was asking, with the method efficacy of condoms of around only 80%, whether you actually focused on whether there was consistency on the use of these condoms among the women who reported to be using condoms. Thank you.
Hello, you can hear me?
Yeah. Yes, Prof, we can hear you.
Yes, I'm sorry I was offline for like a second because I had power outage.
Okay.
So I may have missed something.
I'm kind of inviting Amelda to take the questions. I need to step out a bit. Amelda, continue.
So maybe as we are waiting for Amelda to come in, maybe Prof, you can start responding to some of the questions that were asked.
Yes, thank you, Mary, and thank you for the questions. I think the first question I got was the sub-county data. We have not done the sub-county level analysis. We'll look at it. Depending on the power we have, then we'll be able to advise whether we can drill down to the sub-county level. I think there's a chance, but we have to look at that data, whether it's consistency of the data. In terms of condoms, we did not go into details in terms of consistent use. What we wanted to know whether condoms were being used for purposes of family planning. Part of the reason why I did not go into those details is we know that the HIV program regularly tracks that particular indicator in terms of consistent use of condoms. And I think the other question was the method discontinuation, the leaking bucket. We have data on method discontinuation. We have not analyzed that data. We have Canada data, 2-year Canada data. DHS corrects 5-year Canada data. So we'll be looking at that data later on. And I think there was a question about gaps identified where Dr. Misiani correctly noted that these are questions to the CHMT. And I guess part of the gaps identified is what is going to be addressed in the afternoon in partnership with the partners and the county CHMT. So I don't know whether in between when I was logged out because of power outage, whether there was another question I may have missed. Mary, was there any other question I may have missed?
No, the other question was about what the county is doing in terms of implant stockout. Maybe Amelda can respond to the county specific questions.
Yeah, okay. Thank you.
Amelda, you're back. So
for stockout is still a challenge to us because we still rely on KEMSA to give us FP commodities. So we were deciding, I don't know if Dr. Lamenya is on. Dr. Lamenya, are you there, the county pharmacist? Maybe she's out a bit because we are having a meeting. We were planning to see how we can be able to purchase some of the FP commodities, but we have not yet concluded, but still it is still a challenge. That is where we are for now. Hello. Hello.
Yes, Amelda, we can hear you.
Yeah, I was talking about the stockout. We still have a challenge for that. I was just saying that the county is looking at a way if they can start purchasing the FP commodities, but we had not yet concluded.
Okay.
Yeah, any other question that is county specific? I don't know. We continue?
Yes, yes. So from the chat area, we have the question, is there any information on contraceptive failure, particularly for implants? Maybe Prof, you can respond to that.
Mary, again, that's a very important question. There is data showing that particularly individuals who use concurrent other medications, there may be more likelihood of implant failure. The design of our study is not, we may be able to pick up those points in the next time point for data correction, because you have individuals who are using implants now, and you'll be able to find out whether they became pregnant when they are having their implant. We don't have that data right now from our study. But the other study showing that if there are concurrent use of other medicines with implants, there can be failure, particularly in the HIV setting, and appropriate counseling is provided to those individuals. So we'll probably be able to find that information, and I hope, Michael, you note that question so that we can be able to ask that question in the next round of data correction. Persons on implants, they fail, but actually we'll probably try and ask generally for any person who has been on a family planning method, whether they have become pregnant while on the method. So that would be an important question to find out. Any other question from the chat? I don't have the entire chat with me.
Amelda, back to you.
I have a question.
Yes.
On adolescents having sex. Some of the things that we have find out during our dialogue sessions is that they normally engage in sex for material gain. So I don't know whether that was an area of interest and whether it contributed to adolescents also having sex. And secondly is what drives MCPR? Because we are seeing an increasing, uptake of implants, but the MCPR is going down. If you are to compare maybe with other counties, for example, where uptake of DMPA is quite high, is there any difference that counties that are having, like, for example, high uptake of DMPA, we are seeing the MCPR going up compared to counties with that are having high uptake of implants? And maybe you can also give us some expert opinion in terms of method efficacy and when you look at DMPA vis-a-vis the implants.
So thank you for that question. So it's a very clinical question. Let me start by looking at adolescents. And indeed, we asked the circumstances and the first episode. We did not have the of whether it was transactional sex, where sex happened because there were materials exchanged. Maybe we'll put that as an option in the next round of data correction so that we can see how many will say they had that episode, first sex because of material gain. We also have questions about the last sex episode. We can also try and find out that. However, we know the HIV program is asking those questions consistently because transactional sex is a driver of unprotected sex and therefore potential for HIV infection. So we look at it as a project and see, are we going to add value by going to those details, whether when another program is collecting such information. But we'll be able to look at it. And it's an important question. What drives MCPR? Clearly, I think there are two things here. One is availability of the product. Two is people being enabled to access the product. And three is the facilities having the staff to provide the products.
Yes.
The question you are asking is actually the question of a couple years of protection. And that we can calculate that, a couple years of protection. But in terms of, is it implant which will drive MCPR? Is it DMPA? Is it condoms? So if the methods are available and people are counseled appropriately, it means they can be able to use a method which is suitable for them. Remember, there's a choice and there's a clinical opinion. You could choose to have an DMPA. However, you have varicose veins and therefore it becomes not suitable for you, although your neighbors are using it. So I think what you're seeing here is not driven by the fact that it is implant going up or the DMPA going down. It is the fact that people are probably not accessing the products they require. And they may not be accessing them, like Melda has mentioned, because there could have been stockouts.
Yeah.
That's something, again, we are going to look at. We can look at later on a couple years of protection, and you can see what couple years of protection are happening. The question of DMPA and implant in terms of efficacy. It's both of them are very efficacious if appropriately used. And now, remember, there's typical use and there's perfect use. Perfect use is where, for example, the implant would be under the category of perfect use. That once it has been implanted, so long as you don't keep rubbing that site of the implantation, and so long as you're not on another method, then you'll be able to have nearly 100% protection. Now, is influenced by typical use, because repeated 12 months later, and got week 13 or week 14, or sometimes you come at week 10. So the longer you stay, the interval, although we know DMPA stays in the system for a longer time, the longer you stay away from the point of the appointment, the less efficacious it becomes. So efficacy is looked at those two areas, perfect use and typical use, because perfect use would be the most efficacious. Typical use is the common usage, where people may have, like we have just talked about implant. If you're on a drug which kicks up the liver metabolism for destruction of drugs, then the drug will be much quickly metabolized at the liver as compared to a person who is not using that particular medicine. So efficacy here has to be carefully looked at to be able to say, am I looking at perfect use or typical use? I hope that explains those three questions. Thank you.
Okay, thank you, Prof. I have seen the chat box, Dr. Nasimiu asking about the linkage of findings to reproductive health bill. Maybe if Daktari, if you are around, or if you are still on the screen, you can ask the question properly. Dr. Karo Nasimiu. Oh.
Amelda?
Yes.
You can hear me?
Yes, I can hear you.
I think my question was on the RH policy, or is it bill that has evoked a lot of discussion across the country, especially evoking quite some reaction from the religious group of people. And I was just trying to link, because we are to link these findings to some form of actions. And I think a policy at that level would really be a high level action. So I was trying to look at how then these findings can be used to inform that policy at the national level.
Thank you, Daktari. Do you, Prof, any other question? So that
Yes,
maybe
if I
Prof
can. Yes, if I can add up with my other question, I think it's a question that there's one in the chat box, you can look at it, but the other follow-up question is about, I know that the last survey that they did in 2019 was before the pandemic. Maybe the next one this year is during the pandemic, and the next one. So my question.
Well, technicians, please help us.
I'm off the screen. I'm off the sound.
Yeah.
So let me just put the question in the chat box then. Let me put the question in the chat. Okay.
True.
Okay, so Imelda, thank you. We did a national dissemination, and this information was shared at the national level, and has already been taken up by Division of Family Health. So indeed, and remember we said the Minister of Health takes leadership in this project. So the findings indeed are with the ministry, and they can inform. However, the bill, the reproductive health bill by Susan Kiheka, which has seated a lot of debate, the information herein can inform. Because for example, when you look at the number of adolescent and young women engaging in sex before the age of 18, it is very telling. It is there, 48%. So it's something we cannot run away from. But in terms of, this is for Kakamega, I'm not looking at the national data. In terms of, there are elements within the findings which can then help us to think holistically about these issues. Are there differences between public and private facilities? Yes, indeed there are. And we have not analyzed that data into details. We can look at that into details. The question of COVID-19 pandemic, yes, that is true. We did the survey before the pandemic, but you also know that we have done another COVID survey, which we finished in June, and we'll be sharing those findings very soon. So we are now looking at sharing the findings at the national level, and then we'll be coming back to the county to share those findings. Indeed, our next round of data collection, November, December, will take to consideration some of the questions which can be relevant for COVID-19.
Okay, thank you, Prof, for that. I've seen Rafa Mwenesi's also, our question is in the chat box, Rafa.
Okay, thank you, Imelda. I think the question the Rafa Mwenesi is asking is that what is PMA team and counties and the national team planning to do to avail perfect method mix in spirit of self-reliance in the county?
Yes.
Yeah, so that's a good question. I like to make the distinction that as a PMA project, we are responsible for measuring what other people have done. So the design of our project is not intervention, but to be able to measure what other people are doing. It would be a conflict if you are able to intervene and measure what other people have done, because then we'll be measuring our own interventions. So for that reason, there is a clear distinction that we do assess what people are doing, and we are able then to report appropriately. While if it is, for example, now that's what we're saying with the partners and the counties can sit together and be able to say, as a county and as partners with certain responsibilities, how do we ensure that the method mix, I would say there's no perfect method mix, but the method mix is appropriate for the population. Thank you, Imelda. Back to you.
Thank you, Prof. Any other question before we move on? I think maybe we are done with questions, Prof. Eric Mwanga, you have an observation, you can give us that?
Thank you, Amelda, and thank you, Prof, for that wonderful presentation. Looking at the slide that you presented on the myths and misconception about family planning being only for the married women, and looking at the entry point where you are saying that the majority of the people you are interviewing in terms of literacy level, it is down. There is usually a disconnect, especially for the unmarried adolescent, when you talk about family planning and when you talk about contraceptives. So I would suggest probably, if it is possible, we can look at that question so that it is asking about contraceptive and not FP, so that they are able to look at it as a method of preventing pregnancy and like looking at it as a way of planning their families, because most of them feel they are not married and therefore the issue of family is not an issue for them. But when you talk about contraception, for them, it becomes something they can pick. I don't know how that is on your end.
Thank you, Eric. Back to Prof.
Yeah, thank you, Eric. Indeed, the question is structured in that manner, that we do not make adolescents respond to family planning, rather respond to contraception. So we do take care of that, but for general dissemination like that, we could distinguish between contraception and family planning.
Okay.
So I'll look through the questionnaire again and see how we have phrased that particular question to ensure that the adolescents do not feel.
Thank you, Prof.
Yeah, that's correct. We do not ask them about family planning. We ask about a method a person is using or a method they know. So we are softer not to give the impression that family planning, contraceptives is for family planning when they are not planning a family. Thank you. Back to you, Imelda.
Okay, thank you, Prof. On the chat box, I'm not seeing any other question or any concern. So maybe if we don't have any other question, maybe I can go back to Mary to give us a way forward. Mary.
Thank you, Amalda. Thank you, Prof, and thank you to everyone. I believe we are moving on very well. I don't know whether the county health director will manage to come back for this session, or we can continue and briefly talk about the afternoon session.
For now, he has moved out as a bit, he's having a meeting.
Okay.
So we will continue for now until he'll come back.
Okay, thank you so much. So at this point, I want to invite Joseph, who will briefly take us through what will be happening in the afternoon session. Otherwise, I would like to thank all of you, and I'm looking forward to seeing you in the afternoon session. Thank you.
Thank you.
Thank you very much, Mary. And good morning, everyone. It's only 9 minutes to afternoon. Thank you for Mary for this session. And my role is going to be very brief and is to prepare this team for the afternoon session, which we will be beginning at 2 p.m. So it's just to let us know that we have, this is not the end of this meeting. We have another afternoon session. So we will be breaking once we finish this session around noon, and then we'll have 2 hours break until around 10 minutes to 2, where we will be required to log in. So things to note as we come to this session, the first thing to note is that we have a separate link for the afternoon session. So please, the email that was sent to you, note that there are 2 links. So when you are coming back, please be keen to use the link that is for the afternoon session, so that you don't use the other link, maybe fail to log in or go to another online meeting room where there is no one. So please note that. How we are going to structure, and we are very happy because of the discussions and the very good questions we have received from the team, because actually it will be a very good transition to the afternoon session, which is basically about trying to dig deeper into the presentations Prof has done to us, and trying to see what are the implications in our interventions, what are the implications in our programs, and possibly how does that what does that mean to our policies and programs. So, so how we will do that is that we will first have a session that will break out, that will try to tease what the data is speaking to us, which will be done by Sam, and Sam will be taking the entire facilitation of the afternoon session. And based on that, we will be able to break out into different groups through Zoom. And the IT team here will be able to assign you to different breakout rooms in Zoom. So you don't need to worry about that. What you will do is that you will just see an invite to a breakout session on Zoom, and please accept, and you'll be automatically taken to a discussion group within Zoom. So how we intend to do the breakout session is that we intend to do that based on your roles or what you do. So please, I have seen that a considerable number of people have indicated their names and their specific roles in the chat box. So if you have not done that, we request that you update your name and your role you do, because when we are assigning the different groups on Zoom, we'll be able to use that and try our level best to allocate you in a breakout room that is relevant to what you do. That includes the county team, county CHMT, sub-county CHMT, county officials, and also our partners. So please, if you have not indicated your role in the chat box, we are happy to see you have that, so that it helps us know which group to allocate you. We are also aware that we have some people who are joining in this meeting as a group, maybe 2 or 3 people using the same laptop or the same phone. So in such case, there are 2 options to do this. You can either break out and and use your own gadget separately to join the afternoon session, or you could still join as 2 or 3 people using one laptop. But if you do that, please let us know, so that 3 of you can put you in the same group. If you are physically in the same place, please do let us know, so that we are able to put you in the same group. Otherwise, we encourage you to use separate gadgets to join the afternoon session, and that will facilitate you, and it will be helpful for you to join the breakout session. We do not have a specific preference on what gadget would use to join the afternoon breakout session. So either a phone or a laptop would work. But our IT guys here do request if you can use the laptop, the better. The other thing is, in our morning chat, I've seen someone who has asked whether our team here could check on the communication or there were breakdown on you hearing us. So that is most of the time dependent on either our connection of internet or your connection of internet. So if you see that problem, try to check on your internet connection, and also from our side, we'll try our level best to make sure that we have a good internet connection. So I think that's a brief of what we have. We'll continue guiding you in the afternoon session on what is expected. And also during your breakout rooms, you'll have a representative from this team who will be able to guide you through what you'll be doing in that breakout session. The other thing I'm being informed is that on our chat, we have some people who have joined with the names of their phones, like we have Galaxy A20, we have someone's calling themselves admin, we have Galaxy A51, we have Oppo F5, Oppo F9. So we are not able to know these people. So please, when you are joining the afternoon session, we kindly would ask you to use your official name so that who is who. Even now in your chat, you can, if you are using phone, please let us know if you are Galaxy J4. Let us know your official name for purpose of facilitating the afternoon session. Okay, so you can either talk to Joseph or Corey and let them know your name, or you can input that in the chat box. So that's for now, for brief of what we expect in the afternoon session. We really appreciate your participation. I have seen that we have been more of over 50 participants. So please welcome to, we will be happy to have all of you in the afternoon session. So please, as you have joined us, we also welcome you in the afternoon session, which will be also 2 hours, but we expect them to be very packed with group presentation. So we'll try our level best to make sure that we have the best out of that. So that was the brief from me on what we expect for the afternoon session. And I think I will pass it back to Amelda. If Amelda, you have anything to say to the team and to also welcome them to the afternoon session. Thank you very much.
Okay, thank you, Joseph. Mine is just to urge our colleagues from the MOH, please let us meet at 2 p.m. and be able to share this information. It has been a very good presentation, very educative, very informing, and let's continue even afternoon so that we can be able to have more information that even can be able to help us improve our family planning indicators. Thank you very much.
Thank you, Amelda. Maybe as we are closing, if you could allow me make some announcement in terms of logistics. So we will be taking care for the data bundles you are using to connect to these meetings. We will also be sending you a token for your lunch. So, and that will happen in the course of the day. Otherwise, thank you so much, and we appreciate your participation. Back to you, Amelda.
Okay, thank you. I think it's now we will break for lunch. Then we meet at 2 p.m. Yes.
Sure.
Thank you. Bye.
Thank you. Bye.
Goodbye.
Bye.
Bye.